Today I'm going to talk about just an overview of trigeminal neuralgia. I think as you look at the program, we're going to go we're going to get some great granularity in the different treatments for trigeminal neuralgia, but I just want to set the stage today for trigeminal neuralgia. Can you please advance to the next slide? So these are my I just want to make my relevant disclosures, which I am a consultant for Stryker. Next slide, please. So I think what's really, I think many of us are in the room or in this conference today because we're talking about facial pain. And in particular, when we talk about facial pain, as Dr. Nixdorf said, we have to really take a listen to the patient's symptoms. And, in the case of trigeminal neuralgia, for example, can you go to the next slide, please? Patients present with very characteristic pain. I tell people almost if patients present with trigeminal neuralgia, they present with what they call sharp stabbing pain, electrical pain, or like zapping pain. And oftentimes this pain lasts from a few seconds to a few minutes to sometimes an hour, but then it, stops. It's episodic. Patients say sometimes eating, drinking, or cold wind can trigger the pain. And most of the time it's on one side. However, I do have patients who present with pain on both sides. Okay. Down here in the bottom right is a picture. It's a cadaveric picture showing that the trigeminal nerve splits into three distributions. They call it V1, V2, and V3. V is the Roman numeral for 5, which is why we call it V1, V2, V3. Next slide, please. And so, if you don't mind going to the next slide. When patients come, they tell me that they have facial pain. Oftentimes we're trying to figure out what the cause of the pain is. And so, a lot of people come to me saying that I have trigeminal neuralgia, but oftentimes there are other things that can cause facial pain. In fact, this list is just scratching the surface, right? I've seen people who present with having shingles or herpes zoster in their face. As Dr. Nixdorf said, dental disease is a big part of facial pain in a lot of patients. I've seen patients have problems with orbital disease, autoimmune diseases, and even tumors. Next slide, please. And so, most of the time, and why is it that people get diagnosed with trigeminal neuralgia first? It's actually because it's the most common cause of face pain. And, it causes a significant amount of, not just pain and suffering in patients, but it impacts our society, not just in the cost of care, but also in lost work hours. Interestingly enough, though, even though it's the most common cause of face pain, it's only about 15,000 new cases are diagnosed per year. Now, if you think about it, it's 15,000 being diagnosed every year. It's like a bucket that's filling every year. Every year, there's more and more, which is why we see so many. But about half of them go to surgery, and they often do really well. What's interesting is that, as Dr. Nixdorf was talking about, oftentimes patients have seen a dentist. There's some sort of dental procedure, even orbital trauma or face trauma can trigger this, and nobody understands why. They're not sure it's causative, but it's definitely an association. And in general, it happens in older patients. However, I do see a significant number of young patients who present to me. Next slide, please. And so, next slide. I'm so sorry, everybody. There's a very, in the top right, the top left of my slide, it just, for some reason, I can't see it. So, when people present with trigeminal neuralgia, or they're told they have trigeminal neuralgia, they always think that they were diagnosed with it because they said they saw this on it. They saw a vessel compressing their nerve on an MRI. But I think what I want, and I think what's most important to understand, is that when you make the diagnosis of trigeminal neuralgia, it is a clinical diagnosis. And what does that mean by clinical diagnosis? Clinical diagnosis means that you don't have an MRI, you don't have a CAT scan, you don't have a blood test to be able to tell you what's causing trigeminal neuralgia. It's actually just based on clinical symptoms. And so it's a double-edged sword because, you know, if you have the characteristic symptoms, we can kind of say you have trigeminal neuralgia, but if you don't, oftentimes I always tell my patients, we can't just be so confident that it's the cause and not look for other reasons for facial pain. But, you know, as we said, the most common reason for patients coming to see me and being diagnosed with trigeminal neuralgia is that they see this vessel touching a nerve. And if you look down in the bottom right here, you can see, hold on for 1 second. You can see that there's a vessel touching the nerve here in the bottom right. Okay, next slide, please. And so how this is diagnosed is on an MRI scan, or how they make this determination is on an MRI scan. Go to the next slide. And what they do is they get these high-resolution scans. Sometimes they call them Fiestas, Drive FISP, whatever the proprietary name of it is. It's just based on the machine that they're using. And so next slide, please. So if you look, can you just slowly progress through the next 4 slides? If you look here in the right, and I don't know if you can see my mouse or not, but right in front of the brainstem, you can see a little vessel going over the nerve. Can you see my arrow?
Sorry, doctor, we cannot.
Okay. Well, they're going to go over this in more depth in the MVD talk, but basically, in this case, this is what the findings are that people come to see us with. But again, what I want to stress is that this is not a pathologic finding. Just because you have a vessel touching the nerve doesn't mean that you have trigeminal neuralgia. At the end of the day, it's a clinical diagnosis. And what that also means is that sometimes when we treat patients, we're trying to take care of patients for their pain, but we're not necessarily, we don't always know the cause. Next slide, please. And next slide. So then people say, well, why is it that why is this MRI so important? So the MRI is what I tell people use to rule out other things. So as an example, you can see in these 2 MRIs, these 2 patients came with facial pain and they ended up actually having a tumor. And the tumor was actually causing the face pain. Sometimes other things that can be seen are things such as multiple sclerosis. They can see inflammatory conditions. They can see infections. The MRI is very important because sometimes we can find the other cause of facial pain in patients. Next slide, please. So, you know, today they're going to talk a little bit about treatment. And so once we get, a lot of patients do very well with medical treatment. They're treated with things such as Tegretol, Baclofen, and Dilantin. And if you notice the treatments, and most people who've had medical treatment in this audience realize that these are all seizure medications. And so what many of us believe is that this condition is probably a seizure of that nerve, like a mini seizure, which is why you're getting this facial pain. Some people believe that the artery rubbing on the nerve can cause the myelin or the insulation to rub off, and the nerves are literally short-circuiting. And that's why these seizure medications work, but we don't ultimately know that cause. But, you know, when patients who, and most of the time, though, patients respond very well to these medical treatments. Next slide. But, you know, there are a subset of patients who either become resistant to these medications or the medications just fail them. You know, there are some great surgical options which are going to be discussed in detail today. There's something called the microvascular decompression, the rhizotomy, and the radiosurgery. Next slide, please. Next slide. So, later today, they're going to talk a little bit about a rhizotomy. The rhizotomy is what I call an ablative procedure. If you just look at the three procedures kind of from 30,000-foot view, two of the procedures are what I call ablative. What they're doing is they're causing some damage on the nerve to stop the nerve from short-circuiting. The damage is usually not permanent because the nerves have this ability to regenerate. And then the microvascular decompression is trying to really fix the problem, and that's a more durable response. But this is a rhizotomy. Basically, you put a needle right here at the cheek, and you pass it right up to the bottom of the skull, and you try to burn the nerve either with a chemical or heat. And it works very well. Next slide, please. The microvascular decompression, which I think Dr. Brown and Dr. Sakula will talk about, again, works on the idea or that concept of trying to, next slide, please, take an artery off of the nerve. And, Dr. Janetta did a lot of work on this. On the left, you can see the vessel touching the nerve, and on the right, you can see the cushion pushing the artery off of the nerve. Next slide. Historically speaking, though, it's interesting. Dr. Janetta really perfected the procedure. Walter Dandy, who was the second chairman at Johns Hopkins, was the neurosurgeon that was thinking about, was actually the one who thought about trying to take the artery off of the nerve. So I think you're going to get some great historical context later. The last one is called stereotactic radiosurgery. And again, this is an ablative procedure. Basically, what you do is you take tiny beams of radiation and put it on the nerve to cause the nerve to be damaged and stop the nerve from seizing. And, that's a non-invasive approach. And again, has been very effective, but there are pros and cons. Next slide, please. So, as we go through this, people will talk a little bit about, I think in today's world, they're going to talk about cost. Sometimes when people show you these slides, and I've seen lots and lots of these slides, of course, the microvascular decompression is more expensive than some of these things called the rhizotomies and radiosurgery. But I say you always want to go back to the original concept of these treatments. The microvascular decompression is to really take the artery off of the nerve and try to cure this. And so I tell people there's usually a one-time cost, and then with these other procedures, you'll have to have it done repeatedly over your life. And so it's an additive cost. Next slide, please. And so, I think over the day today, I'm just kind of summarizing the success rates and the complication rates of all the different treatments. In general, all the different surgical treatments work really well and can be very successful. You just want to be at a place that does a lot of these. Complication rates vary. If you do an ablative procedure, there are higher rates of numbness. There's a small chance you can make the pain worse, such as with the rhizotomies or with radiation. The microvascular decompression has a high chance of not causing side effects, but it is more invasive. And so, as you can see, for example, the facial numbness rates are significantly higher with the radiofrequency, the glycerol rhizotomies, as well as with radiation compared to microvascular decompression, because you're not damaging the nerve. And but the recurrence rates are higher, obviously, for those procedures because you're just trying to nick the nerve, and so the nerves will naturally regenerate. Next slide, please.